A thorough hand evaluation is crucial in individuals with leprosy because the disease commonly affects peripheral nerves, leading to sensory loss, muscle weakness, and deformities in the hands. Early detection of nerve impairment through detailed sensory and motor assessments allows for timely intervention, helping to prevent permanent damage, disability, and secondary injuries such as burns or cuts that go unnoticed due to loss of sensation. Regular hand evaluations are essential for monitoring disease progression and guiding appropriate treatment and rehabilitation strategies. Start your evaluation by holding the patient's hands. Observe the skin, looking and feeling for areas of dryness. Dry skin may be an indication of autonomic neuropathy. Note any muscle atrophy, clawing of the fingers, presence of wounds or ulcers, and decreased length in the digits. Observe the tips of the fingers and both sides of the hands. Look for signs of pressure such as callus formation or ulcerations. If callus is present, there can be an underlying hemorrhage or skin necrosis. Are there cracks in the callus? Open wounds can be a portal for skin bacteria that can cause infections and place the patient at risk for osteomyelitis. Is there visible atrophy of the thenar eminence proximal to the thumb? Atrophy of this muscle group indicates involvement of the median nerve. Look at the hypothenar eminence proximal to the fifth finger and the first dorsal inner ossei on the dorsum of the hand. Atrophy in either of these muscle groups indicates ulnar nerve involvement. Once your physical examination of the hand is complete, in Section 2 of the form, describe the location of wounds, callus, redness, dryness, increased temperature, or visible problems in the hands. In Section 5, indicate open wounds, clawed but mobile hand, contracted or stiff joints, amputation or absorption of bone and wrist drop. Palpation of the nerves in leprosy can be a challenging task even for the seasoned clinician. Differences in physical size, tightness, and thickness of the skin can make nerve palpation difficult. Most nerves will not be easily palpable unless they are inflamed and enlarged. When palpating the nerve, we are looking for tenderness and/or enlargement. In the upper extremity, the three nerves most commonly involved are the ulnar, median, and radial nerves. To palpate the ulnar nerve, bend the patient's elbow to about 45 degrees and using the tips of your forefinger and middle finger, find the cubital tunnel and locate the nerve. Slide your fingers just proximal to this space and gently move the fingers back and forth. Ask the patient if the nerve is tender or painful to palpation. If the nerve is enlarged, it may feel to be the size of a number 2 pencil. Palpate the median nerve on the volar aspect of the wrist just proximal to the hand. Because of the tendons that cross the wrist and cover the nerve in this area, palpation is very difficult, and it is rare to actually palpate enlargement of this nerve. If the nerve is involved, however, the patient may complain of pain or tingling in the thumb, first and second fingers, and the lateral border of the ring finger, which corresponds to the median nerve distribution. Tinel's test can also be employed to evaluate involvement of the median nerve. The radial cutaneous nerve is located on the lateral aspect of the forearm, just proximal to the anatomical snuff box. Using the tips of your fingers, slide across the skin in this area, feeling for enlargement and tenderness. When enlarged, it may feel like it is the size of a strand of spaghetti. Indicate the presence of enlarged and tender nerves in Section 4. Nerve palpation. Sensory evaluation of the hand is conducted using a set of 5 monofilaments that assess sensation levels ranging from normal sensitivity to a complete loss of deep pressure perception. Due to the subtle pressure applied by the thinner filaments, each site must be tested 3 consecutive times to ensure accurate results. Follow the hand diagram to identify testing locations and start with the 2.83, the lightest monofilament, and progress to heavier ones as necessary. In order to obtain an objective result, the filament test must be conducted properly. Position the patient so that they cannot observe the filament touching the skin. Use of a barrier or simply asking the patient to close their eyes is sufficient. Have the patient give a positive response each time they feel the filament. Apply the filament perpendicular to the skin surface being tested and apply just enough pressure to bend the filament, then remove it. Application and removal of the filament should take approximately 1.5 seconds. Do not bounce the filament and do not hold the filament against the skin. Test each site 3 consecutive times and then move to the next location. When the patient gives a positive response, record the score in section 1 of the hand screen. If you feel any of the patient responses were suspect, you may go back and retest those areas. Manual muscle testing of the hand is conducted to determine the level of motor nerve involvement. The intrinsic muscles in the hand are small, therefore less force is necessary to test the individual muscle groups. Applying too much force may give you the false impression that the patient has weakness. To test ulnar nerve function, support the medial aspect of the patient's hand and ask them to spread their fingers apart and hold this position. Using your index finger, apply force to the proximal aspect of the patient's index finger. Attempt to bring the index finger down against the middle finger. Next, have the patient place the hand in a tabletop position as shown. Make sure the wrist and fingers are straight and the hand is flexed at the metacarpophalangeal joints. Using gentle pressure with your index finger, attempt to extend the 5th metacarpophalangeal joint as the patient resists. In a patient with normal strength, gentle pressure will not extend the joint. To test median nerve function, have the patient hold the palm of his or her hand up and then raise the thumb straight up so that it's perpendicular to the palm. Apply force to the most proximal aspect of the thumb in the direction of the index finger. Next, have the patient bring the tips of the thumb and little finger together. Attempt to separate the fingers by applying resistance to the most proximal aspect of the thumb. To test the radial nerve, support the volar surface of the patient's forearm just proximal to the wrist. Have the patient fully extend their wrist. Compared to the hand muscles, the extensors of the wrist are strong, so more force is required to rule out weakness. Apply a generous force to the dorsum of the hand in an attempt to flex the wrist. Record your results in section 3, muscle testing, as strong, weak, or paralyzed. Muscle grades of 0 through 5 can also be used. Once you have completed sections 1 through 5, use the information to determine the patients who grade in section 6. If the patient was able to feel the 4.31 or 2 gram filament at all sites, they have protective sensation and are given a grade 0. If the patient does not feel the 4.31 filament and does not have any HD-related deformity, they are given a grade 1. If the patient does not feel the 4.31 monofilament and has HD-related deformity, check WHO grade 2. Patients with grades 1 or 2 should be referred to an occupational therapist specializing in hand therapy. The patient will require education to prevent injuries and may require other interventions to prevent long-term disabilities. If you would like more information on performing a hand screen or have questions regarding Hansen's disease, contact the National Hansen's Disease Program at 1-800-642-2477 or visit our website at www.hrsa.gov/Hansen's-disease.